They were they were initially developed in 1964 by the National Academy of Sciences and the National Research Council, and they have four different classes. There's clean, clean contaminated, contaminated, and then infected. So first of all, class one wounds are by definition uninfected, an uninfected operative wound without entry into the pulmonary, GI, or GU systems. These actually include minimally invasive surgeries like robotic surgeries for some renal tumors and adrenal tumors as well. Um, the Now, due to the long-standing practice of perioperative prophylaxis, the contemporary baseline rate of infectious complications without antimicrobial treatment is available for very few procedures. So it makes the decision to not give prophylaxis in these cases really a venture into the unknown and makes a lot of people uncomfortable. So I think that a lot of times antibiotic prophylaxis is still given during these procedures, but it's really being called into question, in recent times, whether this is actually necessary if we're using good sterile technique. That being said, let's say an exception to this rule is in the case of prosthetic implantations. Although they technically fall into this wound class, there is a substantial risk of infection with prosthetics with coagulase negative staphylococci, gram negative bacilli, and then Pseudomonas species as well. And coverage for all of these microbials has been recommended in the case of prosthetics. So that's kind of one exception to that rule. Class 2 wounds are clean contaminated. These include wounds that have controlled entry into the pulmonary, GI, or GU systems with no other contamination present. Um, these include any opening into the GU tract in urologic surgeries, such as nephrectomies, where we have to cut the ureter, cystectomies, endoscopic cases, as well as vaginal cases as well. The truth is, though, that prophylaxis for these class two procedures need to be tailored to the specific procedure itself, and that comes in two ways. First of all, we have to take into account prior urine culture results, the local antibiogram, and the patient's associated risks. And then also we have to kind of look at the procedure itself and see what the risk of that procedure itself is when it comes to infection. For example, and we'll get into this a little bit later on, but for cystoscopy and urodynamic procedures, even though they're technically clean contaminated, we don't necessarily need antibiotic prophylaxis due to the relative non-invasiveness. So, overall, this really introduces a little bit of confusion within this class, as there's a wide variety of procedures that are really considered clean contaminated, but they don't necessarily all need prophylaxis. And for that reason, a little bit later on, we'll get into a little bit more detail about, what clean contaminated procedures should definitely have it versus what we can consider not having it. Before that, we'll talk about class 3 wounds. These are by definition contaminated. They include things like infected stone procedures, transrectal ultrasound guided biopsy, using bowel segments for reconstruction. And the risk of surgical site infection over here is substantially more than the previous two classes. The recommendation for antimicrobial prophylaxis is a little bit more stable in these types of procedures. There is still kind of a broad association with SSI risk, but most of these procedures will require some form of prophylaxis. Then for class 4 wounds, these are by definition infected. They include things like open trauma, if there's an abscess present, if there's bowel perforation or spillage that's beyond what's expected. And again, by definition, these are considered infected, and they will need antibiotics during the procedure. The general idea is to start broad and then narrow based on any culture that we collect during the procedure. Another important consideration when it comes to class 4 wounds is that some cases that start off as another wound classification could quickly morph into a class 4 wound, and therefore that should be taken into account during the procedure if a wound becomes infected, if let's say we are putting up a stent and we do see pus draining from the system, then we can broaden our antibiotics, and then of course take a urine culture at that time to find out the exact antibiotic that we should be using in order for coverage in that case. That is class 4 wounds. So now, as we briefly mentioned, these classifications don't always accurately depict the actual risk of surgical site infection with respect to urologic procedures, specifically in the clean contaminated class. And for this reason, we can stratify urologic procedures based on the actual associated risk post-operatively. So first, we'll have high risk procedures. These include things like endoscopic prostate procedures, transrectal ultrasound guided biopsy, PCNLs, urinary diversions, especially with large bowel and enteric fistulas. These are considered high risk, and these are the cases where we would want to consider antibiotics pretty much all the time. Then we have intermediate risk procedures. These include ureterorhinoscopy, vaginal surgery, any controlled GU entry. Prosthetics fall into this class, although they should probably go into high risk either way. They're considered intermediate. TURBT, urethral reconstruction, and then urinary diversion with small bowel. And these we'd consider antibiotics most of the time, although in some cases it may not be necessary. And we should also take into account patient risk factors as well. And then we have relatively low risk procedures, include things like cystoscopy, urodynamics, stent exchanges, catheter removals, VCUGs, and diagnostic laparoscopies, where in some of these cases we might not even have to consider antibiotic prophylaxis at all. This is kind of just another lens of viewing the procedure to see if if we're really should be considering antibiotic prophylaxis versus maybe not. Now, so based on these groups, we can kind of highlight a lot of the common urologic procedures that we do and go over the first line antibiotics that we should be using. And then maybe even talk about some of the second line options that we could also use, on a case by case basis. So we can start off with cystoscopy.
Eli, quick question,
Yes,
Eli. Where did we get that classification from?
This classification, I found it in an AUA update series. I don't have the reference readily available, but I can send that to you if
No,
you'd
but
like.
that's from AU Update series.
Yeah,
Okay. Okay. Thank you, Eli. Appreciate it.
no problem. So starting off with cysto, and cystoscopy doesn't just include diagnostic cysto. It can also include just minor manipulations, if we're doing, let's say, an in-office mucosal biopsy, maybe a small fulguration. These are all included in kind of this low risk class. And the use of prophylaxis in these cases is questionable. Other patient risk factors should be taken into account. If we do consider antibiotic prophylaxis, then gram-negative rods are some of the more common organisms present at these sites, and that's what should be targeted if we're considering antibiotics. Single doses of either Bactrim or Augmentin would be sufficient for coverage, and those can be given about an hour before the procedure, so to prevent infection. Over here, along pretty much all of these charts, there's some second line treatments that could be considered. I won't go through all of them because it gets a little bit repetitive, but a lot of times we can sub, or in this case specifically, we can sub with either a first or second generation cephalosporin. We can consider aminoglycosides and ampicillin, which is an aminopenicillin, or to go a little bit broader with something called estrianam, which is a carbapenem, and possibly an ampicillin as well. And like I mentioned, this is a single dose, so you don't need to give any more than that.
So,
Next, we
Eli,
have,
Eli,
yes,
just
sir.
another quick comment about Bactrim. Sometimes we are reluctant to use Bactrim because of allergic reaction, and rare cases of the Stevens-Johnson syndrome has been reported. And Bactrim consists of trimethoprim and sulfamethoxazole. A lot of this allergy comes from the sulfur component of Bactrim. So there is a drug called just trimethoprim we could use. That way it will reduce the allergy and probably as effective. So something to consider. We used to do this commonly when I was practicing in England, but I have not done that here. I'm not sure it's available or not. Just from a theoretical point of view, to consider the allergy actually comes from the sulfur component of Bactrim. Okay. Thank you.
Uh, Thank you, sir. I haven't heard of using, I don't think I've ever seen anybody use trimethoprim on its own. I'm not sure why it became so common just to combine them, but yeah, maybe
It
something
is
to consider in the
available.
future.
I've used it trimethoprim by itself in the past. Oh, and let me say it used to be available in the past. Thanks.
Yeah.
Thank you, sir. So the next specific procedure that we'll talk about is TUR cases, which we most commonly do is, let's say, TURPs or TURBTs, but can also refer to prostate ablative and enucleated procedures. And similarly to cysto, gram-negative rods are the more commonly encountered organism in these cases, but because they're relatively invasive, we don't necessarily we kind of consider antibiotic coverage in basically all of these cases, and not necessarily like we don't hold antibiotic prophylaxis. And the first choices are, in fact, cefazolin or Ancef, and we can also use Bactrim in these cases as well if we'd like. So those are kind of the first line for TUR cases. There's only a single dose that's indicated for therapy. You don't need to give any more of that as well. This changes a little bit when it comes to transrectal guided biopsies. Um, these are a relatively common general urology procedure. We do a bunch of these, but we deal with a much broader variety of bacteria like anaerobes and bacteria that are multi-drug resistant because we're going through the GI tract. So those are a little bit those are a little bit more heavy hitting bacteria. So for transrectal ultrasound guided biopsy, antibiotics are actually recommended in all cases. First line are fluoroquinolones or first or second generation cephalosporins and an aminoglycoside, or we can also just give a third generation cephalosporin alone. This is something I didn't go through before, but cephalosporins come in, I believe there's 5 generations of cephalosporins, and each of them have an increasing spectrum coverage as we go through each generation. So cefazolin or Ancef is the first generation. We can get to cefuroxime or cefotetan, I believe, are second generations. Rocephin ceftriaxone is a third generation. We see that commonly when they give that to potentially infected stones. Cefepime is a fourth generation. Forgot what our fifth generation is. I think it's ceftaroline. I forgot exactly which one that is, but it's not very used commonly. I don't see it very often. But at least a third generation cephalosporin that could be given alone for a transrectal ultrasound guided biopsy. Another thing that has to be taken into account for this population is they're more at risk for multi-drug resistant patients and patients who receive systemic antibiotics in the past 6 months. If they traveled internationally, or even healthcare workers should actually be given broader spectrum antibiotics in these cases to account for that MDR status. And then another thing that we have at our disposal that we might want to use is actually consulting infectious disease to figure out the optimal antibiotic to use. Now, backing up a little bit, we can go back to ureterorhinoscopy. And similar to cystoscopy, GNR are the most common organisms. There is an increased risk for infection over here because of invasiveness. There's this concept of pilovenous backflow that also increases risk for infection. And for this reason, prophylaxis is recommended in all cases, unless the procedure is purely for diagnostic purposes. So maybe for a diagnostic ureterorhinoscopy, it's not necessarily necessary. And then similar to before, first line are either Bactrim or first or second generation cephalosporins. And those are given in a single dose as well. Now, percutaneous procedures are a little bit different as we have to cover for the typical GU organisms that we all talked about, but then skin flora are at risk as well over here. So we can consider going a little bit broader in these cases. So for this reason, in combination with relative invasiveness, Prophylaxis is recommended in all cases, and in these cases as well, antibiotics could be given for up to 24 hours. So not necessarily just a single dose, depending on their risk for their increased risk for subsequent infection. So you'll see over here that the first line includes things like first and second generation cephalosporins that we're used to, but in certain cases we can also consider aminoglycosides and metronidazole to cover some anaerobes. Aztreonam, carbapenem, which is also relatively broad, and so on and so forth. So it's something to take into account for percutaneous procedures.
Eli?
Yes, sir.
I hope I'm not interrupting too much, but I just wanted to mention here, and since you mentioned these two, ureteroscopy and percutaneous, how the interplay over time has changed, is evolving, that bigger and bigger stones are being done by ureteroscopy. And because the frequency of infection is also related to the length of the procedure, then the interplay between the length of the procedure and the amount of pressure in the collecting system is something that is evolving, so that it is just a changing field where we have more and more kind of high risk procedures done by ureteroscopy that used to be only done by percutaneous nephrolithotomy. So it's just something to keep in mind when we see the size of a stone and the complexity of it. Then, and we go at it by ureteroscopy, then keep in mind the stewardship of the bacteria that might or may not be present.
Absolutely.
Thanks.
And Dr. Marino, you actually brought up an excellent point, and it's something I think that I kind of just brushed over it during this presentation. And that's kind of almost because of what we usually use first line for a lot of these procedures. But another thing that we have to take into account, especially if we're not going with ANSEP, is redosing of antibiotics. Especially for longer procedures, such as ureteroscopy, where that can go for multiple hours for large stones. We have to take into account this idea that if the antibiotic is if their timing of action is not as long as the procedure is, then we may need to redose them as well. In those cases, I believe ANSEP is a 24-hour long dosage, so I'm not sure if it's necessary. I don't think we have anything that lasts 24 hours, but something else to take into account in these cases.
Yes, thank you.
Thank you, sir. So from there, we'll also talk about shockwave lithotripsy. This is actually considered a completely clean procedure, and antibiotics are only indicated if the patient has other associated risk factors, but are usually not necessary in these cases. Bactrim should usually suffice, but again, we can use cefazolin or second generation cephalosporin, or anything else listed over here. But really should only be given if there are really patient risk factors for infection and is not necessarily necessary. Now, penile surgery is interesting in that, relatively non-invasive procedures like circumcision, even though there's potential exposure to skin bacteria, at least according to this update series, prophylaxis is actually not required. And our practice actually reflected this, when we were doing circumcisions in the clinic. I don't believe we gave any antimicrobial prophylaxis. Dr. Costa, you can correct me on that if you'd like, but I don't remember us giving any antibiotics for those procedures. We don't commonly do them in the clinic anymore, so I don't remember. But that's something
there is the only procedure that I've ever prophylaxed for in the office routinely is transrectal ultrasound biopsy.
Mm-hmm. Right. So, and this kind of reflects that where, a circumcision like that, prophylaxis is not necessarily required. That being said, more invasive procedures such as urethroplasty or urethrectomy do require single dose antibiotics. And first line is cefazolin. We can use other cephalosporins or aminopenicillins as well as first line. That's the recommended duration of therapy is just a single dose. Interestingly enough, unlike simple penile cases, inguinal scrotal cases that I thought would potentially be relatively simple. So things like radical orchiectomy, vas reversal, or hydrocelectomy do entail a higher level of risk and require prophylaxis in all cases. In these cases, ANSEF or cefazolin is the first line. We can use ampicillin sulbactam as a second line if we'd like. And these are indicated for up to a single dose. And like I said, all cases should be covered in this way. I don't believe vasectomy itself falls in this class either. It's, I think, an important distinction over here. Those don't need antimicrobial prophylaxis either. Now, another procedure that we do pretty commonly here is those involving the vagina and vaginal flora. And these have an intrinsically different, flora than the regular GU flora that we encounter in other urologic procedures, including species such as streptococci, enterococci, as well as vaginal anaerobes. So for this reason, prophylaxis is indicated in all cases due to this more diverse microbiology. And second generation cephalosporins are the preferred antibiotic for coverage, although cefazolin is equivalent in coverage for vaginal anaerobes and can be used in sling procedures for that reason. They have, just enough coverage in order to cover, but the first line recommended is actually second generation cephalosporins. And they list a couple over here, such as cefoxitin or cefotetan that we can use. And the single dose is also enough over here. Now we'll get into some robotic procedures. These are procedures that do not enter the urinary tract. They're considered clean cases. And in these cases, prophylaxis is actually not necessarily indicated, which kind of surprised me because they seem somewhat invasive, but at least according to this, it's not necessarily necessary. ANSEF would be the first choice if it is determined to be necessary, and it could be given as a single dose. We could use clindamycin as a second line if we'd like as well. So that's if we're not violating the GU tract. Now, if we do enter the urinary tract, such as in nephrectomies, cystectomies, we talked about them a little bit before, then it goes back again to like a clean contaminated procedure, similar to cysto, but relatively invasive, and antibiotic prophylaxis is indicated in all cases. ANSEF and Bactrim are enough and could be given in single doses for these cases, but they are in fact indicated. Now, in terms of bowel, robotic cases that enter the small bowel are actually similar to those that enter the urinary tract with exposure to flora such as gram-negative rod, Staph aureus, and enterococci. Cefazolin is more than sufficient to cover these as part of the first line, but entering the large bowel is actually different. They carry a greater risk for infection from a broader range and a higher concentration of bacterial flora, which includes anaerobes. And in these cases, cephalosporin monotherapy does not suffice, and we need to go a little bit more broad, whether that's in combination with something like metronidazole, or I believe we had a recent case with Dr. Daly and Dr. Balaji, where her first line antibiotic was something called Envans or ertapenem, which is a relatively broad spectrum carbapenem. But we can also consider things like piptazo, piperacillin dazopactam, which is I don't know if this is an aminopenicillin or just a regular penicillin with a beta lactamase inhibitor. It's considered somewhat of a big gun, but yeah, those are we definitely need to go a little bit more broad when we're considering large bowel cases. And then
Eli,
finally, yes, sir.
Dr. Daly typically like you said, Dr. Daly typically uses the ertapenem. Are we okay? I typically, if I'm going to do an exent, I cover with ANSEF and Flagyl, thinking that colon may be involved. You just don't know. Is that still appropriate? Should we be using ertapenem?
At least according to this chart, it looks like cefazolin and metronidazole are sufficient, or some other cephalosporin just in combination with Flagyl should be fine. I don't know what her consideration is specifically in using ertapenem. Maybe she knows something that we don't. She uses bowel a lot more than us. I can actually ask her about this because it was it was an interesting choice when we were in the OR. They were very quick to say it. It was just very understood for them that they were going to be using NVANs. So I can investigate a little bit more and see what their consideration is there.
Eli, one other comment, Eli, if we use third generation cephalosporin, ceftriaxone, is it still necessary to use metronidazole? Does
I
ceftriaxone have any anaerobic cover?
I don't believe so. I can go back to my chart from before and see whether they report on it, although I'm not sure if they have the specific generations of cephalosporins, but I don't think third generations cover anaerobes.
Anaerobe, okay.
No, ceftriaxone does not cover anaerobes.
Does not cover anaerobe. So we need to cover with either with metronidazole.
Metronidazole.
The thing is, yeah, I see that footnote there that they say we use oral antibiotics like neomycin, erythromycin base. I think we have moved away from those. We don't use them anymore. So just FYI. So, okay.
Thank you, sir.
Thanks.
And then finally, last but not least, we have to talk about prosthetics, something that we commonly use in urology. They're a class in and of itself. They carry a prolonged risk for infection from relatively common organisms, as well as infection from anaerobes and fungal organisms as well. The prophylaxis is always indicated in these cases and could be given for multiple doses. There are a range of first-line options for antibiotics when it comes to prosthetics, but importantly, cefazolin monotherapy is not sufficient in these cases. There needs to be some type of combination. Dr. Costa, for your penile prosthetics, I believe you like a combination of Venk and Gent. Is that it? I could be mistaken. And then another thing that needs to be considered in these cases is potentially antifungals. There's no specific recommendation. They're not always routinely recommended, but can be considered for specific at-risk cases. We're not going to get too much into antifungals. We're not going to get into it at all, actually. But I just wanted to give that special mention in the prosthetics here because that's really when we could really consider that indication. All right, so in general, in summary, these lines that I've been memorizing for the past 2 years and change, it's really likely sufficient for most cases. As we can see, cefazolin, Ancef is really the first line antibiotic that we use. But some really take-home points that I found interesting when I was going over this is that there are some cases where we actually may be overusing antibiotics. The SSI risk is small, and it's something that I'd like to kind of think about further and maybe question, if we're not in such a big rush in the OR and, we really want to kind of remain good stewards of antibiotic activity. It's also important to recognize why Ancef works and what bugs we're actually trying to tackle with prophylaxis. And that should really be taken into account when we can't use Ancef, whether it's because of an allergy or, maybe it's just unavailable for whatever reason, God forbid. So that's another thing that I took out of this. And then most importantly, we have to value this tool that we have. Antibiotics are fantastic. They really decrease our complication rate, but we have to respect them and we can't be too liberal with their use because this thing of antibiotic resistance is becoming an issue, and we want to make sure that we're able to use them for as long as period as possible. So thank you very much. That's my presentation.
Thank you, Eli. I think that is a very good topic to discuss, and I appreciate your presentation. That chart is excellent. And one of the things that I wanted to know if you have any comments on is whether the most recent statements by the AUA, somebody commented that the Mayo Clinic residents are so up on the AUA guidelines and recommendations. And did you come across any of those in your study of this?
I didn't see anything super recent. I'm not sure if you saw anything.
Well, the last thing that I see is from 2020 by Deborah Leitner and Luke Cavuzzi and others, covering data from 2018. And it's the best practice statement on urologic procedures. it's a little bit different than guidelines, I think, but anyway, the end result is the same. And simultaneously, there's another initiative called the EDGE, Urological Disease Group Excellence Consortium. And that is a kind of another group, multi-institution group that studies the infections in endourology. And they're made quite a few statements on percutaneous nephrolectomy. So anyway, those are just two recent. The EDGE group consortium has more current studies and are a little bit bigger. So it's been more recent studies. So anyway, those are the two, one of several sources of guidelines, so to speak. Thanks.
Thank you, sir.
In your review, did you come across any guidance with regard to patients with other prosthetics? For example, if they have had a hip replacement within the last 6 months or 2 years, or if they have a prosthetic heart valve, how
So
do
I did go come across that briefly. I neglected to include it here. Maybe I should have. I didn't want this to be too long, but I believe that in general for heart valves, it's things that I'm sure we've all heard that for certain dental procedures they require prophylaxis, especially when patients have a history of heart valves. I think for most GU procedures, it's not necessary to cover to use antibiotic prophylaxis if they have a history of heart valves. Now, when it comes to hip replacements, I think the rules changed a little bit. Like you said, there's kind of this timeline where that they're more at risk for infection, and we have to take that into account when we're doing our procedures. I forgot the exact timeline, I'm sorry to say.
So there was a case, I think it was within the last year, where a guy had a hip replacement, and then 6 weeks later was going to have a prostatectomy. And so I had to talk to Dr. Shaner from Ortho about it. I don't know if this is part of their guidelines. I'm only able to tell you her specific advice, but she told me that he didn't need anything else besides the standard prophylactic coverage with ANSEF during the procedure.
Thank you, Devin.
Thank you, Devin. My recollection is, so maybe the timeline has changed. We used to use the 2-year mark. If it's beyond 2 years, then you just do what you're agnostic to the fact they've had it, but it's within 2 years. Maybe now it's 1 year, so that might have changed. And with the prosthetic valve, I think it depends whether it's mechanical valve or not. If it's mechanical, then we tend to be more aggressive with antibiotics. So, I mean, just for our purposes, we need to think of other indications, just not the procedure itself, but this is the patient risk factor you were talking about, Eli, to factor in. There's a lot of our patients.
Absolutely.
Yes.
Yes, sir. Thank you.
Eli, can you hear me?
I can hear you, yes.
Yeah. So, quick question. Your presentation seemed to have just covered the immediate period before surgery. Is there any thought about post-surgical prophylaxis? For instance, we tend to give antibiotics when we take out the catheter post-prostatectomy. And the reason I'm asking is you had mentioned, but you had asked the question whether some of these antibiotic prophylaxis was necessary. I'm just wondering if you have any comments on that.
So, at least according to this review, just for simple catheter removal, antibiotic prophylaxis is not necessarily necessary. There are certain things that we may need to take into account. Along with the catheter removal, we have to take the specific risk factors into account. But from just like a bird's eye view, no other risk for infection, no, relatively healthy patient, we don't necessarily need to give antibiotics for catheter removal.
One research project that maybe it's already out there, and anytime we think of an idea, we need to do a thorough literature search, make sure it's not redundant. When Beshad was here, he looked at the incidence of urinary tract infection. It's a composite thing, including UTI symptoms as well as admissions for patients undergoing trust biopsy. And he did this meta-analysis, and he gave us two things. He said 3 days of antibiotics is better than 1 day. And he also taught us that the rectal swab with iodine does decrease it. So that's what we have implemented in our practice. What may now be useful, Eli, now that you have looked into it, is to truly look at what is the incidence of SSI in our patients and how much does antibiotic actually contribute to that decrease? Because, we're using sterile techniques, simple things like wound irrigation. Towards the end of the procedure, we flush everything before we close, and we do a lot of things. And are they sufficient? And can we forego antibiotics? Like one provocative comment today was, if we do a nephrectomy or a adenectomy, we don't even need antibiotics if you're doing them robotically, because the amount of skin exposure is a lot lower in robotic than open. And the other thing is open incisions are open to the atmosphere for an extended period of time, whereas with minimally invasive, it's always a closed system. So the body is not exposed to any more infection than normally when they're not undergoing surgery. So these are things to look into. Maybe the incidence is extremely low, and we may be able to forego antibiotics for more of these patients. And that may be an opportunity to review, Eli, if anybody is interested in that.
Yeah. It is interesting, sir. And as I mentioned before, there is a lack of research into this. I think the one of the reasons is that people just don't really want to take that risk, because if you, like you mentioned all the way at the beginning of this presentation, these types of outcome measures are things that we are, paid on, and, we're evaluated on. So, it's like, I could further decrease the risk of surgical site infection by just adding a little bit of antibiotics. Why don't I just do that so that I avoid, a potentially very poor outcome, even though it might not really decrease that risk, but there's a lot on the line.
Yeah, no, I agree with you. So I think it may be worth just looking into, and if there is some value, put the data out there. Then it's up to individual practitioners
Yeah,
to decide what's best in their practice.
absolutely.
Okay.
All righty.
Okay.
Any other questions?
If none else, great talk, Eli. Thank you for doing that. Really appreciate it.
Thank you.
Thank you.
Thanks, everyone.
Thank you. Bye-bye.